Okay, we're going to start because I hope more people filter in. This should be a very popular session. This is, pain is something I don't think we talk enough about in NF, and we don't treat it enough. So I hope, I'm guessing that you guys will have lots of questions. The way it's going to work is I'm going to introduce the three speakers. Dr. Yohay is going to give a little brief intro about NF and pain, and then we're going to open up the questions. So let me introduce everybody. First is Dr. Charles Argoff, who is a professor of neurology and director of the Comprehensive Pain Program at Albany Medical Center. He specializes in pain management and chronic headaches, predominantly treating patients with chronic and neuropathic pain. He's a member of the International Association of the Study of Pain, the American Academy of Pain Medicine, and the American Academy of Neurology. He also serves on the editorial board of the Clinical Journal of Pain. Next is Dr. Frank Buono, who I think many of you must know. Dr. Buono is an associate research scientist in the Department of Psychiatry at Yale University. Dr. Buono wants us to know that he was diagnosed with what was called neurofibromatosis type 2 at the age of 9. This, along with his professional training, provides him with a deeper understanding of the physical and clinical manifestations of the disease, as well as the co-occurring diseases and disorders. His research focuses on the treatment and impact of chronic pain within individuals with NF, and he's currently funded through the CDRMP, CTF, and other private organizations. And finally, I'm sure also many of you know Dr. Kaleb Yohay, who is an associate professor of neurology and pediatrics and the director of the Division of Child Neurology at NYU Grossman School of Medicine. He co-founded the Johns Hopkins NF Center in 2002, and since 2014, he's been a director of the NYU Langone Health Comprehensive Neurofibromatosis Center in New York City. His medical practice is devoted entirely to care of children and adults with NF1, NF2, and Schwannomatosis. And he's particularly interested in developing best practices for symptom screening, treatment, and age-appropriate anticipatory guidance for children and adults with NF. So thank you, all of you, for participating. And I'll ask Dr. Yohay to start to talk about about NF and pain.
Is this working? Yeah. So good afternoon, and I just want to start off by, we're just going to spend about 5 minutes. I'm just going to give a little background about the implications and importance of pain in neurofibromatosis in general. And then we're going to spend the rest of the time answering questions and just talking about how we manage pain and think about pain in the NF population. So as you just heard, I take care of both adults and children with NF, so across the entire age spectrum and also across all three main types of NF, NF1, NF2, and Schwannomatosis. And as a result, I deal with treating pain for this population on a daily basis. And I want to just talk a little bit about what pain is before we sort of hit the main part of today, just so that we're all sort of on the same page. And also, not intentionally, but I realize also as an excuse, I'm going to be talking about how complex pain is. And I have to say, overall, we do a really lousy job of taking care of pain and treating pain, not just in NF, but in general. We do our best, but there's so much more that we can do to treat pain well, and we just aren't there yet. And part of that is the biologic, social, emotional complexity of pain and the experience of pain. So what is pain? I mean, part of the definition of pain is that it is a combination of both the experience, the emotional experience of a sensation, plus the physical and biologic aspect. So pain is not just, you press a button and you have a particular experience. It's processed at all different levels of the nervous system. So pain is a receptor in your finger. It's processed by the nerve that transfers that signal to your spinal cord. The spinal cord itself does different things with the information. The information gets to your brain. It gets processed at a different level. And it has an emotional component as well. So we all know that if we stub our toe when we're, playing a sport and in a good mood, we just sort of keep going. If we just had some bad news or had a really rough day and we stub our toe, the experience of that pain is totally different and can be entirely disruptive, where in the other situation, you just keep going and you ignore it. So pain is complex. It's also complex in that chronic pain and acute pain are totally different. So if any of us stub our toe, we know that that pain can be the worst pain ever for about 10 seconds. And your experience of something that is temporary and acute is very different than if you know you're going to have that pain or a different version of that pain every day for the next 6 months. And pain biologically in the acute phase versus the chronic phase is also very different and responds differently to treatments. And we have to adjust how we treat patients who are experiencing chronic pain versus acute pain. The approach is totally different. Some of the changes that go on are actually permanent or semi-permanent changes that go on inside the brain, inside the spinal cord, in the nerves. And so, treating it, treating a chronic pain that's been going on for months with Tylenol is not going to do the same as treating a new headache with Tylenol. Right, so all that being said, again, pain is very complex. There are different types of pain. So there's pain that's sort of mediated by the nerves. Then there's pain that's mediated by what's going on inside our body, inflammation, pressure, things like that. And we divide pain into different types. People with NF have pain for all kinds of different reasons. So we have patients that have tumors on a nerve, and maybe there's pain that's caused by that tumor. But people with schwannomatosis may have diffuse pain that's started by pain from a tumor, but then chemicals are released into the body that cause sort of a hypersensitivity to pain. That probably also happens in NF1 as well. We don't fully understand how that happens or why that happens, but there are both local and generalized pain syndromes that can be associated with NF. We also know that people with NF1 in particular have a lot of potential for bone growth issues. So things like scoliosis can cause asymmetry in the body and cause musculoskeletal pain. People with NF can get headaches. People with NF have stress in their lives, which can exacerbate pain. There's a higher incidence of depression and anxiety, which can also make pain worse. People undergo surgical procedures, which also can cause a different kind of pain. So pain comes from all these different directions and sort of comes together to meet in the NF community in such a way that it can be really hard to treat. And I think as we go through some of the questions that will come up, I think you will hear from us that really the approach to treating pain has to be, because pain is coming from all these different directions at the same time, our treatments have to address multiple different aspects of pain at the same time. And that's where we, I think, have a lot of trouble. Anything you guys wanted to add or?
I just wanted to emphasize what you just said by saying that treating pain when it's in NF, but in general in chronic pain, is the opposite of treating a strep throat with an antibiotic.
Right.
The expectation in the second situation is that you take the medicine for a couple of days, it goes away. It doesn't seem that we've captured that yet.
Right. And treating pain, I think, then becomes a partnership between the treating clinicians and the patients, because we can only try something and we can't know if it's going to work until we try it. And unfortunately, to some extent, this falls on the patient to sort of let us know whether or not it's actually.
It's a real partnership.
Yeah, it's a real partnership.
I think you also have to include being the only psychologist up on here, is that you have to include what Kaleb, Dr. Yohay was talking about earlier, which is pain is a biopsychosocial model, and that's the best way to go treat it. And so you have to bring it from the biology. You have to understand the biology, which is where the MDs come in, But then the psycho, which is psychology, and the social component, which is, my area of expertise, which is, how is it affecting the individual? And Dr. Yohay brings up anxiety and depression, and how does it affect, your society, how your family structure goes? And there's components with that as well, because this is very complex. And so, using empirically based, evidence-based modalities like acceptance commitment therapy or cognitive behavioral therapy are been shown to be effective, and we have to consider that as well.
If I could say just one more thing,
No,
sorry.
no, absolutely.
I would urge anyone listening to say how complex things are. I would also like to emphasize that we can work on this together, and it's definitely, pain is treatable. We hope that we're going to answer as many questions as we can today, but this is treatable and surmountable, and we can work with each other. So we're saying that we would like to cure it. You're hearing our anxiety.
Yeah.
We would love to be able to say, but we are going to work with people with NF, and we're going to help as much as possible, and we can make a big dent in your pain.
So here are two questions that are somewhat similar, but I think it's riffing off what you guys both all said. Why is pain so difficult to manage? And then what barriers to pain control have you seen in your patients? And anyone, Dr. Argoff, why don't you start?
Sure. I mean, as has been mentioned, pain is every part of our nervous system, and you're anchored by two neurologists, so we'll keep each other in check, okay? But every part, our nervous system is like the biggest information processing system ever, bigger than, more complicated than I think any supercomputer so far. And so things that happen, the only way we know what happens in our periphery is because our brain, our central processing unit, is working. Things can happen in our central processing unit, and NF can affect both peripheral and central nervous system areas, can influence how we feel everywhere else. And so they're just, pain is complex because every part of our nervous system has an opportunity to weigh in on it. And it's that complexity, it's really, again, the opposite of saying you have strep throat, we're gonna get rid of that infection and you're done. And so it's a very integrated system. And we're getting at each day at picking away at the complexities, but it's end, as you mentioned, and at the end of the day, it's how we behave and feel and what that pain does to us.
You want to respond?
Yeah.
Why is it so difficult to?
Well, so, I mean, from the patient perspective, I'm sorry, my voice is generally loud, so I generally move back from the mic.
Two microphones?
Yeah, sure, why not? Yeah, it goes back to my ego, but I think that it's the patient coming to us, right? The patient has to say that they have pain first off, and a lot of times when I am doing my research or I'm doing clinical components, people don't talk about their pain, and they say, "Oh, my pain's not bad." Well, if your pain is actually really bad, but you're diffusing the pain and you're not actually accepting that you do have pain, then there's limited ability that we can do to help you out. So that's one issue from the patient perspective that I think that it needs to be discussed. If you have pain, you need to tell us, right? And then we as providers or psychologists need to acknowledge it and then help you find a resolution to dealing with that pain.
I would also say one of the reasons I think pain is hard to treat is that from an evolutionary perspective, pain is actually really important. The whole purpose of pain is to let us know that something is going on that's not right. And so our body and entire nervous system is built to create an alarm system that we're not supposed to ignore. So we're trying to override something that is hardwired into us that we're not supposed to be ignoring, but we're trying to. There was another part to your question.
Yeah, what barriers to pain control have you seen for your patients?
I mean, that could take all.
I really want to
day.
start.
Somebody asked if you want to start it, maybe these guys could continue. You don't have to start, but
I think it's a great question. I mean, there's so many barriers and so many frustrations. Insurance is a big one. Access to medications that work and are effective. I mean, there's I think especially in the current era of fear around opiates and I mean, justified fears, and there have been major issues with how drugs have been marketed for pain, but it has made access to sometimes effective therapies for patients more difficult. So
I just want to add, and I don't mean to sound nasty, but you know I'm from Brooklyn, so we just talk, but I'm not nasty. But I think that you know the reality is, and you could tell me and us more, but I think it's fair to say that sometimes the provider you see doesn't listen to your complaint of pain. And it's the last thing on the list of the 7-minute appointment that people have these days. And somehow the pain isn't important. And as you pointed out earlier, chronic pain, it's almost like the nervous system has changed. This is crazy, but this is, I think, pretty true, that a person experiencing chronic pain, not if I pinched Frank, Dr. Buono, and that I'd be doing acute pain, I'm not going to do it. But if you have chronic pain, which NF is associated with, it's almost like the nervous system has changed to facilitate that. It doesn't make any sense because pain is supposed to be protective, but now the nervous system says, well, this is what I'm experiencing, so I'll make it happen better for you. Yeah.
It's one thing, sorry, I get used to it, I'm sorry. The one thing that I'm just going to counter is that it's sometimes not the 7th question, it's the first question which is asked, and it said, okay, what's your pain scale on a 0 to 10 scale, right? Everyone's probably been asked that, life, if you've had any regular checkup with a doctor. And that's a complex question in itself, because you could have multiple different areas of pain. You could have multiple, variant levels. So what do you say? Do you say, oh, my right arm, my left leg, which I was pointing to my right leg, but that's, sorry. And so that's an issue. And then then the doctor might not ask any more questions on that. So it's your job to help advocate for yourself and say, okay, it is my right arm is a 5, my left leg to 3, but it's gone up from a 3 to a 4, and that's something which is perturbing to me. And so you need to be, one thing that I tell all my clients is that you need to advocate for yourself when it comes to chronic pain. If you have something, you have to say it.
I just want to add, even in the non-NF world, this study done at the University of Wisconsin in Madison by a colleague of mine who ran that pain center for a long time. The average number of painful conditions that a person comes to that chronic pain center with is 2.7. So I emphasize what you just said.
I completely.
Well, so here's an easy question for you that's going to generate some controversy. What is your preferred method of pain management?
Effective pain management.
Okay.
That was easy, right?
Would you guys like to elaborate? Because I think you're each going to have.
Do that.
Well, yeah, I think you're each going to have a very different answer to this.
I think it's individualistic. You
Right.
can't say what's good for Dr. Yohay is good for you, and so I think it's, going to a provider and talking to them about the situation. I'm going to lean heavy into, the psychosocial methodology of cognitive behavioral therapy or acceptance commitment, but I'm also going to say there are other complementary or alternative treatments, that can be effective. And not to put, too much history, but, as I said, I've had an NF2. I was paralyzed from my hips down at the age of, when I was in the middle of my doctoral dissertation. I had to take a year off school, had to really learn to walk. One thing that helps me, and I deal with chronic pain every day. One thing that helped me is yoga. I do yoga every day. Now, it may not be effective for someone else who has steel rods in their back. So, but it's looking out at other treatment modalities that could be effective.
You have anything to add to that?
I'll give the flip side. So 100% there is there's no single pathway, but there are certain approaches that you can take based on the type of pain that you think someone has, whether it's chronic or acute, whether it's neuropathic or not neuropathic. I would say for the majority, and absolutely with Frank, I also recommend, in addition to using medications, which I use in many patients, I often recommend other modalities such as yoga, commitment therapy, acupuncture, a variety of different things. But I do have a set sort of pathway that I will use for most patients in terms of escalation. I'll start with something that I know is low risk, like something like gabapentin or Neurontin, for someone that I think has neuropathic pain. If someone has a more sort of inflammatory kind of picture, I might use a drug that sort of targets inflammation first. I'll then move up to sometimes I'll use drugs like Tramdol or other opiate-related medications if the neuropathic medications don't work. And then I might move up to a category of drug called SNRIs or SSRIs, especially something called duloxetine. So I think a lot of us develop our own sort of stepwise progression. In the end, what I'm doing, though, for almost everybody that I treat with pain is sort of throwing something at the wall and see what sticks. Because I may have 10 patients with pain, and maybe that 3 of them respond to a particular drug, but I may not know that until I try it. And so there is a lot of trial and error. And again, that comes back to the partnership aspect.
It might be helpful, just in case not everybody understands the difference between neuropathic and non-neuropathic pain.
Right. So actually, you want to? Yeah,
Sure.
yeah,
But you're doing a great job. So neuropathic pain literally is defined, and this actually was published in our Academy's journal, the definition a couple of years ago, as pain associated with a lesion, so an injury within the somatosensory system. So the somatosensory system sounds like a lot of gobbledygook, is the any nerves in your skin, peripheral nerves leading to the spinal cord and the brain. There has to be a lesion in that area. So you can imagine a schwannoma interrupting peripheral nerve or spinal cord function, and that's where neuropathic pain might be associated. And as you mentioned, NF, I forgot if you said 1 or 2 or both, were maybe associated with inflammatory pain through release of different chemical mediators. Inflammation is a huge issue for the body in general, including cardiovascular disease. And so unwanted inflammation may sensitize and create pain in a different way, but there may not be an exact lesion associated with the nerve. It makes the nerves more sensitive, but that's where the term inflammatory pain might come in. And so those are important distinguishing kind of, so very common conditions like fibromyalgia and migraine are not specifically inflammatory or neuropathic because we haven't figured out exactly what's going on with them yet.
And a lot of what, and back to Frank's point about sort of relying on you guys to provide a good history, it's actually really difficult. Describing pain is really hard. I mean, and I think all of us can think back to something that hurt, but then trying to put words to it can be very difficult. But as best you can, it's really helpful for the clinicians to figure out which type of pain it is and what medication is going to work best by understanding as best we can from you what the experience of the pain is.
So for example, and we've never rehearsed this, okay, but but if someone came to us and said, well, pain's aching and throbbing and dull, that is usually, those are terms that are usually described in non-neuropathic pain. But if someone came to us and said, I feel like there's an electrical fire, I feel like I'm burning, there's like a shock-like sensation, it sounds like it's a wire, right? That it's short-circuiting, but that's what nerves are, they're wires. They carry electricity. And so that would be more likely to be associated with a nerve problem. And I think I just want to go back to a couple of minutes ago. You know, people, how many people here know about being treated for high blood pressure, high cholesterol, diabetes? Those areas suffer from the same concerns we're having, which is how do you pick the right treatment for the right person? How many people can't tolerate statins, which are used for, how many people can't tolerate this kind of insulin, but something else? And if the last 30 people in that person's office were doing great. So we face these challenges all the time in clinical medicine. And it's really important. Well, I like to think of managing pain as the Rocky movies, not because I punch meat or I do jog, but I don't punch meat, but because when no one has to go down, there are so many opportunities to help people, and true evidence-based medicine is using the best available evidence to make effective treatment decisions for the person in front of you. Everything is not going to be in a study. And to your point, everyone has a treatment algorithm or a treatment approach that's based upon your clinical experience and the literature. And we certainly, I'll just put a plug for doing more research in pain in NF, because we do need to have more formal studies to be able to help. But in the meantime, we do have many treatments that can combine lots of different therapies to help.
Just not to plug my own research, but
No, you should.
uh,
plug
you
your-
should
you should
No, I
plug
think
your own
that's the whole
research.
purpose of this
Yeah,
meeting.
oh yeah, I think so. I'm currently doing some qualitative interviews with patients with NF1, and I am finding in my interviews that the patients are not able to describe their pain, and they describe it, they don't understand what burning or stabbing or throbbing or, aching pain is. And so, if, and here's the issue, is if you're having difficulty explaining your pain, it's going to be more difficult for a provider to give you answers. And so what is really needed is, well, a couple of things, I think, is more of a standardization of pain assessments, and what we need to do for NF is to describe pain in more clear descriptors for individuals with NF. Another thing that I think that is really important is if the first question is asked, describe your pain, and you can't do it, you have to provide another way to provide that description. Because if you can't distinguish between an aching, stabbing, throbbing pain, you have to say, well, it happens during this time, and it feels like needles pricking me, or some way to actually give a definition so we can help them.
Well, let me ask you to follow up on that. I mean, many of us treat kids. Kaleb does both adults and kids. One of the barriers I've seen is the kids can't use those words. And I will ask them, I will mention all the words you guys have said, and I don't know, it just hurts. So how do you all deal with that when you're choosing the pharmacotherapy?
One thing that I've always, used for kids is colors. As long as they're not colorblind. I'm colorblind, I can't see it, so, but, and where you go from a blue to a red spectrum and say, okay, how severe is your pain? And, you can make it interactive. You can have them color it out. I've actually had parents, say, take it home with them and see what it is in situ, in the current time when they're having pain. Have them get a chart out and, fill in a box and have them color the box. Sometimes it works, sometimes it doesn't, but, at least that at least gives some narrative to the pain.
Any other comments about kids in pain?
I don't treat children in pain, but I could imagine that we might be able to work together to kind of give an example of somehow translate the experience of stabbing pain into something a child might recognize. Does it feel like you stepped on a nail or something like that?
Have you come across that barrier as well?
Yeah, I think it's a real challenge. I think it's in really young kids. I mean, I think it's we have to rely on the parents' descriptors of how the child looks in a given moment, and probably use other information other than the quality of pain to try to understand what the pain is. So what time of day does it happen? What happens to their face? Is there associated symptoms like nausea? So I think we have to use all of the information at our disposal, and it's less information. So
If I could just add one other challenge
Sure.
that just popped in my head for those of you taking care of children or have children with NF, there are very few FDA-approved medicines specifically for pain relief in children.
And
So,
I'm gonna take one more step if I may.
No,
You know,
yeah.
Staci Martin and her group put out an article in 2013, I believe, showing that opioid medication is not as effective for kids with pain. Now, I'm not saying it's not completely effective, but it shows to be not as effective for NF specific cases.
Let me change the topic a little bit now, because I've gotten several questions about this, and I've heard Dr. Yohay talk about this in other contexts. So the specific questions here, would you say essential oils to be effective or ineffective for pain management with NF and with the tumors that are above and beneath the skin? If it can be effective, what kinds would you be most effective to use? I'm going to broaden that question to complementary and alternative treatments, specifically for pain and NF, if anybody can. And Frank, Dr. Buono has, I got to call you Frank. I mean, got to call her, has already alluded to yoga as an example, but please talk about that.
I'm happy to take a stab.
Sure.
You can all take steps.
Yeah.
So my wife just opened a herbal apothecary, and she's got a graduate degree in public health from Hopkins and a graduate degree in herbal medicine. And it's her passion to help people. And she's a critical care nurse as a background as well, also at Hopkins and other places. And so the point here is that I'm amazed, and she makes every single product that she has put on display. And I'm not going to tell you where it is, or it's not a plug for that.
Yeah, I was going to give you, we'll get a slide.
I mean, I do have a card, but I was in the it's amazing what I've learned just watching her, that there is so much evidence that their different herbs have analgesic properties. We are always familiar with turmeric, but I'm amazed at the benefit of rosemary and calendula, and I can go down a list, and I know it's not necessarily a specific formula. And I think we have not harnessed that approach. And I think it's there is the National Institute of Complementary Medicine. I'm sure they're ripe for proposals from us in general to study. Part of the problem with herbal remedies is that has not been standardization of, as you mentioned about assessments. There haven't been standardizations of what's in. How do you prove what's in the product is there, and then how do you study it in a way that's scientifically valid to make conclusions about, since no treatment is likely to be equally helpful for all people, and we want to know the good, the bad, and the ugly about every treatment, because some treatments may have toxicities. Although there's a lot of promise, I think we have a lot of ways to go, but definitely I think there's something to herbal medicines.
Yeah, and I totally agree. I think one of the real challenges for this population is it's a rare disease with a wide variety of manifestations and with a wide variety in sort of time and until symptoms develop. So the idea of using alternative therapies, dietary modifications, things like that, for symptoms of NF, it's going to be very hard for the medical establishment to take that and run with it in terms of the traditional clinical trial pathway. And it's very unlikely, sadly, that I think we will have good evidence-based medicine for most of the things that people are using. So one thought that I had a few years ago was to look at it from the opposite side. So if something is really effective, and people are trying different things out in the community with or without the help from their physicians, if there's anything that's great, people are going to migrate towards it. I noticed this when I first started going to NF camp down in Virginia, and I noticed that this doesn't have to do with pain, but almost all the kids were on melatonin. Yeah. And I hadn't prescribed melatonin before, and I hadn't really thought about the sleep issues, but there's this convergence. Kids are coming from all over the country with different doctors, and they're all on melatonin. It's because it works. So I did a survey for the NF population a few years ago. I don't know if any of you filled out the survey, but it was through the registry, and just looked at what alternative therapies, herbal medications, dietary supplements people are using. And the things that rose to the top, vitamin D, which I think is being used primarily not for pain, but for bone. But turmeric certainly rose to the top as something that a lot of people are using. So curcumin is the active substance in turmeric. It's been shown to impact both tumor growth and inflammatory pain in both outside of NF and in NF specifically in some limited studies, and it's safe. So things like turmeric, I think, are certainly reasonable to try.
And you mentioned yoga. Are there other
Yeah,
things that
and
you?
so like you have, I mean, there are a lot of evidence-based articles that have shown yoga that's been effective, acupressure, acupuncture, physical therapy, occupational therapy, all shown to be effective. You know, certain things like heat compressed or cold compressed, I mean, they use it, I mean, cold is used in the NFL after you play a football game. I mean, but unfortunately, there isn't any evidence base to say that cold therapy works in the NF population or in most populations. And so it goes back to science will probably never catch up with like using elderberry or using, you know, different essential oils. But it goes back to if it works for you, that's great. I would tell your doctor what you're using so that they're informed, because there always might be a complication of what you're using or, you know, a counter effect to certain drugs. So just be very open and willing to talk about it.
Well, along those lines, also, anybody who's walked down Michigan Avenue will ask this question, what about cannabis?
Anybody
Like
else?
which kind you like?
Yeah, exactly. Have you used it? Is it efficacious?
I didn't
In what
inhale.
Are you asking
circumstances
me
have you used it to treat? Not,
Oh, okay.
I'm not getting into personal use, although it is legal it is legal here.
Yes.
The problem with like cannabis is that, once again, unless you have a cannabis card, it is not regulated. And so if you go to the gas station, in any gas station in Illinois now, you could buy THC gummies. One THC gummy could have 5 milligrams of THC in it. The next one could have 15.2, and you don't know what you're getting. And so that's the problem with, you know, those gummies.
It's even worse than that. We did, clinical pathologist and I did a survey of CBD containing compounds in the Capital District of New York. I'm from Albany, and all the CBD, almost 90% of them had THC in them. And everyone involved in cannabis research understands there's a difference in the central nervous system effects of.
You want to explain that just very briefly?
Yeah, so CBD, cannabidiol is, there are, I don't know, 80, 90, 100 different substances in different cannabis plants that are neurally active. And THC has the, is the part that can cause psychomimetic effects, which means that changes in your central nervous system changes in your mood and it's what makes you high, essentially. CBD does not do that. And many people don't do well with THC containing compounds, and that's where some of the mental status changes can occur and some of the concerns for safety can occur. And so there are places selling in non-regulated settings CBD, it says CBD, and yet we went into all those shops in the Albany area and found that almost all of them had THC in them. And so safety is paramount too.
Can you use them for treatment? Are you allowed to use them for treatment?
Yeah, so I mean, in New York, medicinal marijuana is legal, so I do prescribe it for some patients. On the plus side of it not being fully recreational legally legal yet, is that when you prescribe to a medicinal
Dispensary.
dispensary, they actually do a very good job.
You know what you're getting.
You know what you're getting,
very much.
and I can specify the ratio of CBD to THC, and there are studies that show a 1-to-1 ratio of CBD and THC tends to be, you know, a good place to start for people in terms of pain. And so I'll usually start there. And some patients respond very well, purely anecdotal, and some patients do not. And I've had at least one patient with Schwannomatosis who actually, his pain got much worse after using it.
So please, if you guys have questions based on what's set up here or other ones, please just raise your hand and Salvo La Rosa will bring the mic over to you. But I mean, I have more questions from the app, so.
If I could just say one more thing
Yeah, absolutely.
So one of the instead of, I think it's important also to look at the role of cannabis, not necessarily in, it's not, I don't think any study has ever shown that it's the most amazing pain relieving drug ever in any combination ratio. But what studies have shown is that it can really help, it can help with sleep and improve sleep. And anybody here doesn't think sleep is important? No, sleep's really important. And so that's really helpful overall to a general health of somebody, right?
Yeah.
And it can also aid for some people in anxiety and depression control. And so as we think about how to manage a person's pain, those may be really important features to address with a certain approach.
Any questions in the audience before I keep going on the app? Oh, there's one,
One question.
please. Dale?
Bill.
How do you avoid missing maybe a secondary diagnosis and assuming that the pain is NF related when it could be another ailment? Is it imaging? Is it Q&A? What are some of the things you do to sort of avoid?
The MDs.
Yeah. I'll take it from the NF perspective, and just, I mean, it's always a concern, and actually probably from the get-go, one of the things that we should always be communicating around pain in NF. So pain in NF is not something that just should be assumed is going to be present. So if someone with NF has pain, you can't automatically assume that it's just because of NF and you're just going to treat the symptoms. So especially when someone has new pain, progressive pain, or pain that I can't understand, I'm going to do an additional workup. So if someone has, if a 3-year-old comes to me with headaches and NF, I'm definitely going to do an MRI of their brain. They may just have headaches, but I'm going to do an MRI to make sure it's not something else. If a young adult comes to me with new pain in a plexiform, I am absolutely going to be concerned about the possibility of malignant transformation, and I'm going to do the necessary medical workup to make sure that I'm not missing something that's more, that's more important than just treating the pain. And absolutely, somebody with NF can have any kind of other ailment in the world outside of NF that would cause pain, and it's a lot of history asking and doing, additional workup. I mean, I've diagnosed gallstones, and so it is about doing a good, careful exam and a detailed history also.
Yeah, I'm gonna just add to everything that you just said by saying that you have a low index, always have a low level, always have a high index of suspicion, low threshold to consider if something changes, and if the pain pattern is different, so we always do that. And then if something gets worse, and the other side of not exactly your question is, there are pain conditions in somebody with NF that are not NF related as well, that somebody might have migraine and NF, so they occur that way as well. But I think, I can't tell you how many, I guess I can't tell you. But we get referrals sometimes to our pain center from, people know cerebral palsy, and that's not something that gets worse with time. And we've gotten referrals from people who said, well, I was told that it's just my CP getting worse. That's not the way to look at it. No, right. This is got to be critically evaluated and carefully.
More questions from out there? I'll keep going from the app.
Back there.
Where? I can't see. Lights in my eyes. Somebody back there?
By the exit sign.
Oh, please.
So this may have been addressed and I missed it, but I've noticed that women's pain is often discredited over a man's. For example, my husband has osteoarthritis. I have osteoarthritis as well as NF. Our doctor has given him a higher dosage and more frequent dosages of the same pain medication that I'm on. And I outweigh him by 50 pounds. Why? And that seems to be kind of not par for the course, that women's pain is often more discredited than men's. Is there a possible reason for that?
There's not a good logical, I think I'm so sorry that's happened. I know we all feel the same way. And there's no good logical reason why that should ever occur. I don't know if you want to add.
Yeah, that shouldn't happen.
I mean, I'm not your, we're not your providers, but I mean, at the same time, you have to take that into account, and if your provider is not providing you good service in that sense, it's time to potentially, and I'm not giving you this, but just think about what you need to do to get good care. Yep. And that's definitely a problem. The one benefit that COVID has given us is telehealth. And telehealth has definitely expanded the NF center sites. And so I would be contacting the NF center sites and seeing if they're willing to do telehealth.
And we just published a paper in Pain Physician on how to do a pain assessment in telehealth. And so there are centers across the country that will do that.
That's fantastic.
That is, but of course you can only prescribe for your state though, if they're prescribing.
That is not true.
No, really?
That is not true. That's what having a DEA number is good for.
Oh, yeah.
Okay, cool. Well, somebody asked that same question, how do you find care in a state that really don't have care for NF or really know about NF? I would reach out to CTF and they can certainly help you find a close NF center. Go on, Frank.
I have this one example. I had a patient who was in a clinical trial of mine who lived 5 minutes from the UAB campus. And UAB's got one of the most dynamic NF clinics in the country. And she never even heard of UAB to go have the NF clinic. So I think what Bob said is you contact CTF, contact organizations, your advocacies around, because they might have some knowledge on this as well.
We have a couple of minutes. I have a question here. I treat chronic pain patients with cranial alpha stimulation therapy. Are there data using this treatment with NF patients?
Not that I'm aware of.
Not to my knowledge.
Any more questions? Because we do have some. Yes, ma'am.
So mine kind of goes with what's already been asked. I live in a very rural area. My specialists are over 7 hours away. How do you recommend we talk to doctors or in the ER that think that we're drug seeking when we're truly not, that don't quite understand it?
I'm just going to say something and hopefully it's helpful, because it all depends upon how that ER physician interprets this, but perhaps if it's possible for you to undergo a telemedicine kind of based, where do you live?
That's pretty rural.
Is that really far from Salt Lake City?
It's about 5.5 hours, and that's where my primary is. But there, as everyone knows, there are times when you can't get in. Okay. And chronic migraines, things like that.
So I wonder if the American Academy of Pain Medicine may have a list of telemedicine worthy places, and perhaps by having a comprehensive pain assessment by a pain specialist, and a copy of that, and almost a letter that says, this is someone I'm working with. This person may have flares of, meaning you or anyone else, I may have flares of their pain. This is common. This needs to be treated assertively. please consider that when you make decisions.
Can you say the name of that again so I can?
Yeah,
write it
yeah,
down, please?
American Academy of Pain Medicine.
Okay, thank you.
Sure.
Any last questions before we close this session? Okay, well, thanks very much to this panel. I certainly learned a lot, and I really appreciate your coming.